Hello everyone, my name is Ben Landgraf, and today's topic will be on gaps in knowledge from the basic exams that were given for the year 2023. After the ABA gives every exam, they produce a document that outlines the most misunderstood topics on each exam, and this allows programs to go over these topics to close these particular gaps. My goal here is pretty simple. We are really just trying to take this report and go over these topics and make sure that you don't miss them again. Some of the topics are a little bit challenging to understand what exactly the board wants. So some of the information is sort of extrapolated from what I think they're talking about, but in any event, we'll try to review what we can and hopefully give you a better understanding of the topics that the board is trying to test. So gap in knowledge number one, when sedation is provided by non-anesthesiologists, personnel with specialized training should be involved in the care of the patient. What is being tested here is that in practice, sedation is often given by non-anesthesiologists in a wide variety of settings. Most often this occurs in off-site locations where invasive procedures are done, such as the cath lab, radiology, or endoscopy. The ASA's stance on this practice is that all practitioners who give sedation should have a working understanding of the various levels of sedation and also training of how to rescue patients out of problems that are encountered should they become more sedated than was originally intended. This requires one, knowledge of the various stages of sedation, and two, the problems that can be encountered with each stage. So with minimal sedation and moderate sedation, patients tend to respond either normally or purposefully to verbal commands. Airway manipulation with these two stages is often not needed, and the cardiovascular response to sedation generally is unchanged. When you cross into deeper sedation, patients generally respond purposefully, but only with repeated or painful stimulation. Sometimes airway manipulation is needed, and cardiovascular response may be mildly impaired. With general anesthesia, which is the next stage, no response is elicited unless, even with painful stimulation. The ventilatory response is often impaired and requires manipulation or an airway device, and cardiovascular response may be impaired to the sedative medicines. The key here is that the practitioner who's giving the sedation should be able to have the skills to rescue a patient out of a stage that's one deeper than where they intended. So a practitioner who is intending to give moderate sedation should be able to give a jaw thrust or to treat any cardiovascular impairment that may result if a patient slips into deeper sedation. So continuing on with gap number one, when a non-anesthesiologist prepares to give sedation, they must approach the patient in a similar way to how we approach patients that we anesthetize. They should review things such as NPO status, the risk of respiratory compromise, cardiovascular disease, and ultimately cardiopulmonary fitness. They must plan for standard monitoring of level of consciousness, ventilation, oxygenation, and circulation, and they must plan for discharge after the return of mental, respiratory, and cardiovascular function. Many institutions will use the Aldrete score, which is outlined here to the right, and takes into account patient activity, circulation, oxygen saturation, consciousness, and respiration. Each of these is assigned a score, 0 through 2, and a score of at least 9 is required for safe discharge of the patient. Gap in knowledge number 2 is the specific treatment of opioid overdose is determined by the pharmacokinetics of the opioid that was used. So first we should understand the pharmacokinetics of naloxone. Particularly, 60 to 65% of naloxone tends to be excreted through the kidneys. It is turned to naloxone 3-glucuronide in the liver as well. The half-life is 60 minutes. So the problem that occurs here is that overdoses with longer-acting opioids, such as hydromorphone, morphine, and heroin, and others, may lead to re-narcotization after the original dose of naloxone is given. In these situations, repeat boluses of naloxone or naloxone drips may be required for a period of time based on which opioid was involved in the overdose. The chart over here on the right, it can give you some idea of the time for the effects of various opioids to wear off and the amount of time that you have to be concerned with re-narcotization. It should also be noted that naloxone administration comes with its own problems. It's been well documented that naloxone can lead to pulmonary edema. Also, naloxone administration can lead to increases in heart rate, cardiac output, and blood pressure, which can lead to cardiovascular events in those who are prone to such events. All right, gap in knowledge number 3 is administration of hydroxyethyl starch may result in a coagulopathy. So hydroxyethyl starch is a colloid solution sold under the brand name Hespan, and it's made up of extremely large molecules between from 10,000 to 2 million Daltons, and these molecules serve as extreme volume expanders. They're stored in the reticuloendothelial system for an extended period of time, and this tends to work great, but the main problem with this solution is that it leads to a clinically significant coagulopathy through several mechanisms. So the first mechanism is a dilutional effect. Since it's such a great volume expander, all of the factors get diluted out, and there's some reduction in the ability to begin the coagulation cascade. The second mechanism is that it directly reduces the level of factors 8 and von Willebrand factor. It also reduces levels of glycoprotein 2B3A, which then leads to poor platelet adhesion. And there's direct movement of this solution into fibrin clots. So when taken together, there is a notable and widespread coagulation issue, which is why it is often avoided. Gap in knowledge number 4 is differences in opioid context-sensitive half-times are the result of their pharmacokinetic properties. The definition of context-sensitive half-time is the time required for blood or plasma concentrations of a drug to decrease by 50% after discontinuation of administration after a given time. The concept being tested is that this is the result of the different pharmacokinetic properties of each drug. The specific pharmacokinetic properties can be remembered by the abbreviation ADEM. This stands for absorption, which describes the front end of administration. And remember, the context-sensitive half-time describes the tail end of administration. Distribution, or volume of distribution, where less volume of distribution results in a shorter context-sensitive half-time. Metabolism, where faster metabolism results in a shorter context-sensitive half-time. And elimination, where faster results in a shorter context-sensitive half-time. Each of these characteristics are slightly different for each different type of drug, which creates a slightly different context-sensitive half-time profile. So you can see that this is the graph that's widely distributed whenever we talk about context-sensitive half-time. So each one of these drugs has a curve that's shaped slightly differently based on their specific pharmacokinetic profile. So for instance, administration of fentanyl over a period of several hours, 4, 5, 6 hours, results in a much, much longer context-sensitive half-time than some of the other potent synthetic opioids like sufentanil or alfentanil. The one that is missing on this chart is remifentanil, which ultimately has an incredibly short context-sensitive half-time, regardless of duration of infusion. That's due to the fact that it has very high metabolism and a very low volume of distribution. All right, gap in knowledge number 5 is the anesthetic technique used in total hip arthroplasty can impact the incidence of perioperative complications. So in general, for hip replacement, there are 2 types of anesthesia, either neuraxial anesthesia or general anesthesia. And in a recent prospective randomized superiority trial, it was shown that there were several improvements with neuraxial anesthesia over general anesthesia. In particular, overall mortality was decreased with neuraxial. Thromboembolic events were decreased, blood loss, and therefore transfusion requirements, and ultimately metrics for discharge readiness were obtained more quickly than with general anesthesia. Now it's important to realize that this is for elective hip replacement, not necessarily for hip fracture patients. There was a recent randomized superiority trial from the New England Journal, the link is over there to the right, that didn't show such differences with elective hip replacement. Gap in knowledge number 6 is the physiologic thermoregulatory responses are affected by the anesthetic technique. With general anesthesia, the body's ability to control temperature is impaired, and this happens in a dose-dependent fashion. Vessels dilate, leading to heat moving from the core to the periphery and ultimately being lost to the environment. As we can see with the charts on the right, vasoconstriction and shivering thresholds, or responses to hypothermia, are reduced by at least 1 degree Celsius. The response to temperature with neuraxial anesthesia is similar to with general, meaning vasodilation results in movement of heat outward, but to a lesser extent than with general anesthesia. Regional anesthesia generally has a small effect with regard to heat, as the core of the body is generally spared with regional techniques. Gap in knowledge number 7 is altering the airway tubing used in a circle system will affect the physical characteristics of the breathing circuit. Flow through airway tubing is governed by Poiseuille's law. The variables that increase flow are decreased length of tubing, decreased viscosity, and increased change in pressure between 2 measured points. Because viscosity of fluid is a variable, this means that flow will be optimized if laminar flow is kept. Other variables, such as unidirectional valves and sharp turns within the tubing, will encourage turbulent flow and ultimately the total flow within the circuit. So as a refresher, over on the right-hand side of the screen, a circle system is drawn out with all of the components. So to review, fresh gas is bubbled through a vaporizer, then through the inspiratory unidirectional valve and to the patient. The patient then exhales oxygen, CO2, and inhalational agent through the expiratory limb, through the expiratory unidirectional valve, then past the APL valve, where some of the gas is scavenged, and past the reservoir bag, ultimately leading to the CO2 absorber. The CO2 is removed from the circle system, and then the gases continue to circulate around. Gap in knowledge number 8 is tap blocks can be placed using a variety of anatomic approaches, resulting in different levels of sensory blockade. So in general, there are three approaches to the TAP block: the subcostal approach, the lateral approach, and the posterior approach. The subcostal approach allows for coverage in higher thoracic nerves, approximately from T6 to T9. At this level, local should be injected between the transversus abdominis and the posterior rectus sheath. The lateral and posterior approaches cover slightly lower thoracic nerves, approximately T9 to T12, and local should be injected between the transversus abdominis and the internal oblique. The posterior approach is, as its name suggests, slightly more posterior and is at the level of the triangle of Petit. Some pictures over here on the right show approximate anatomic locations of where these blocks are performed. Gap in knowledge number 9 is the use of transtracheal jet ventilation necessitates different methods for assessing the adequacy of ventilation. So ventilation with jet ventilator leads to less reliable CO2 sampling, since bulk flow does not exist like with standard mechanical ventilation or spontaneous ventilation. Therefore, ventilation must be assessed by either chest rise or by blood gas sampling. Now, when you think about oxygenation, this occurs with transtracheal jet ventilation in several ways. So laminar flow occurs in small airways, and this ensures that gases flow in the middle of these airways and out along the periphery. The Pendeluft effect describes how gases move from alveoli that fill first to those that are slower to fill. Taylor dispersion describes the diffusion of high-velocity central gases to the margins of the airway. And finally, cardiogenic mixing describes the mixing of gases that occur due to the beating heart within the thoracic cavity. Now, that's a little bit about oxygenation and ventilation. Now, of course, there are some risks to jet ventilation as well. So first of all, there's no airway protection, so patients are at risk for aspiration. There's also risk for insufflation of the stomach when this is done, if the needle isn't applied directly into the trachea. There's risk of laryngospasm. Since high velocity gases are involved, there's risk of necrotizing tracheobronchitis. And there's risk of trauma. It's not uncommon to have pneumothorax, pneumomediastinum, subcutaneous emphysema, and of course bleeding during transtracheal ventilation. There's also the risk of air trapping leading to barotrauma if too many breaths are given in succession and enough time isn't allowed for the passive exhalation. Our final gap in knowledge is exchanging an endotracheal tube in the patient with a difficult airway can result in method-specific complications. So we are often called to the ICUs for endotracheal tube exchanges when they have leaks that cannot be overcome by manipulation of the tube or reinflating of the balloon. And there are a great many ways to do this. So some of them are listed here. You can exchange endotracheal tubes through LMAs. You can go over a fiber optic bronchoscope or around a fiber optic scope. You can use combinations of any of these methods. You can extubate over a gum elastic bougie or a different sort of obturator, as is outlined in the picture over to the right. You can use something called a jet stylet, which is a hollow stylet that can, where breaths can be delivered through the stylet. Then there are also various commercial tube exchangers from several companies listed here. Ultimately, this shouldn't be taken lightly because complications such as esophageal intubation, loss of airway, ultimately hypoxemia with cardiac arrest can occur, and also injury can occur to the various structures in the oropharynx and the larynx. These are often more common than the first intubation attempt, since airway and oropharyngeal swelling may have occurred if a patient has been intubated for a long period of time. All right, that's all I have for you. Best of luck as you start your preparations for the basic, which is coming up in June, and talk to you soon. Take care.